Welcome to this special edition of the Mtech Access Words of Wisdom webinar. Today I'm delighted to be joined by Simon Parsons, the Divisional Director of Surgery at Nottingham University Hospital's NHS Trust. Simon is joining me today to discuss what it's like to be responsible for surgical services throughout this COVID pandemic. Against the backdrop of the Trust's recent decision to suspend some non-urgent elective surgery, Simon will explain the challenges his trust and others face in maintaining activity and how they might adapt to provide appropriate care for their patients in the future. Simon, welcome. Thanks for joining me today. Could you briefly introduce yourself and your role, please?
Yeah, sure. Thanks a lot, Tom. I'm Divisional Director for Surgery. We have 2,000 staff in surgery. It's one of 5 divisions in Nottingham University Hospital's NHS Trust, which is one of the biggest trusts in the NHS. Yes, I've been, most of my life has been dominated by the hospital's response to COVID over the last few months.
Yeah, fantastic, thank you. So your trust is obviously under huge pressure at the moment. Can you just summarise how things feel for you and your colleagues?
Yeah, well, we are all pretty tired, and we have spent the last 6 months initially responding to COVID first time round, and there are a lot of lessons that we've learned along the way. And then it was a case of as the first COVID peak dropped, let's get back to normal, let's catch up with all the things that we've stopped doing. And so we were really going flat out on that, and we were just getting up to normal levels and just beginning to dent in the backlog. And then suddenly the second wave hit a little bit sooner than we were expecting and a lot harder than we were expecting. So the staff are pretty tired and having to go again. There's, the morale is not brilliant right now, but we're all pulling together and we'll see this thing through.
Yeah, fantastic. Let's hope so. How does this differ from the first time around?
Okay, so it's really interesting because the first time around, we obviously were completely in unknown territory, and we saw the horror stories coming out of Italy and China, and we pretty much shut down all the non-essential elective work. So endoscopy shut down apart from emergencies, all the elective surgery shut down, outpatient shut down, and we stopped doing everything that was not essential. In addition to that, of course, we had the lockdown, and for certain emergencies also stopped, like major trauma. People weren't driving their cars fast, they weren't outside, they were safely tucked up in their houses, and so we had very little major trauma, which meant that we could allocate those staff to the COVID effort. But also, strangely, a lot of other emergency workload reduced. People stayed away from hospital as much as they possibly could. Whereas now, in the second wave, people are going about their business pretty normally, although we've got different levels of lockdown, and Nottingham is currently in tier 2, although we expect we may end up going into tier 3. Nevertheless, there's still lots of people out and about doing their normal things, working normally. And so the normal emergencies are continuing to happen. People aren't staying away from hospital because there's been a lot of media over the last few months saying, if you have a problem, you should go, and that is correct. But so our emergency workload is still 100%. We're keeping going the outpatient clinics, and we're keeping going as much normal work as we possibly can, whilst also trying to deal with a huge influx of COVID patients. So that's quite a difficult combination. You know, when we were shutting down elective work initially, then we had extra resources to cope with COVID. The other difference is that in the first wave, we used the independent sector a lot, and we don't yet have an agreement with the independent sector to help us with the elective surgery workload. So lots of differences which actually make it a lot more difficult this time round than first time round.
Are there any positives this time, that things that you might be better prepared for or might be easier this time around?
Yeah, well, of course, we do know a lot more about COVID than we did 6 months ago. And, you know, the NHS has been one of the leaders in COVID research, and Nottingham have played a full part in that. And one of the things we're seeing is at the moment, and we hope it continues, that although we're seeing similar numbers of patients needing to come into hospital, quite as high number of patients going to intensive care. So that's encouraging. And, you know, we hope that we will be able to get a lot more patients through the condition. And hopefully, although our intensive care is filling up, hopefully it won't be quite as much of a pressure point as it was in the first wave.
Yeah, okay, wonderful, thank you. You've obviously mentioned about the scaling back of surgery services. One of the first trusts in the country to take the decision to reduce non-urgent elective surgery. Can you just talk us through the decision-making process behind that step?
Yes, okay, so there are two major components to this. The first thing to say, the risk to the patient, and the second thing is resources. So let me just expand on the risk to the patient, because we know that from initial data that came out about COVID is that the patients with the highest risk of death are patients who catch COVID whilst having an operation. So there's really quite an alarming rate that was published in the Lancet. There was a big paper in the Lancet suggesting that about 20% of patients having elective surgery actually died if they had COVID. Wow. Now we were very alarmed by that first time round, and we were very cautious in reintroducing surgery, but actually we have avoided anything like that. In fact, we've had very little COVID related harm in our surgical patients because we've set things up to keep them free of COVID and so forth. But that is nevertheless a concern that we still have, that if our patients in the post-operative period catch COVID, then there is a significant risk to them. So for that reason, non-urgent surgery and non-cancer surgery probably should at this peak be deferred to a later and a safer time. However, of course, one of the risks with any pandemic is that more harm comes to patients without the pandemic, without the COVID, than with the COVID. So we absolutely do need to operate on patients with cancer and clinically urgent and emergency conditions. And, you know, part of my job is making sure we can do that in a safe environment with a very, very low risk of them catching COVID. Yeah,
okay, wonderful. I mean, so, in terms of...
Sorry, so that's the risk to the patient side of it, but also there's the whole resources side of it, and the main decision that we had to make last week, which was well publicised, was the fact that you know, now our hospitals are being overwhelmed with COVID patients, and we can't do everything. There are limited resources, and so, as happens every winter, to be honest, when we have a really bad winter and lots of patients coming in with winter viruses and so forth, then we have to sometimes reduce the number of elective surgery that we do. And that's what we're seeing now. but this time it's COVID, and of course it's only October and we're not into winter yet.
Yeah, okay. And obviously, you know, like you say, we're just starting winter, or winter is around the corner. I don't think anyone's really expecting that things are going to improve within the next few months. But how will you monitor the sort of your level of provision over the next few months in terms of when you might start to either increase that non-urgent work or possibly even, you know, have to scale things back further?
Well, to say that we've been monitoring things day by day is an understatement, because we've been monitoring things hour by hour, and sometimes we've made a decision in an afternoon, and the next morning that decision is no longer true because things have changed overnight. And so we're monitoring the situation hour by hour and taking decisions accordingly. And one of the lessons from the first time round is that we will very much up and down, flex our capacity much quicker than we did first time round. The modelling data, it really has been pretty accurate, and so we've got a pretty good idea of when the peak is likely to be. Of course, we can't say exactly how bad it's going to be, and that depends on, you know, government measures in terms of tier 2 and tier 3 lockdowns and so forth. But you know, we're having to be very responsive to the changes that we're seeing. Yeah,
okay. So you've mentioned the patient risk and the resources as the two key drivers in your decision making. We've spoken with previous guests about the block contracting model and the change in the NHS finances, and obviously that all changed from the beginning of October. Does the financial position, in terms of the amount of activity you're going to be able to achieve over the next few months, does the financial position have a bearing on your decisions around service provision?
To be absolutely honest, no. It's not a limiting factor. The government made it very clear that whatever was necessary they would support, and they have done that, since COVID. We can all look back, and I've been doing this role for 3 years. I'm stepping down now and handing over to somebody else, but over the last 3 years we've been asking for money to do ward, to build new wards with side rooms, and had we got that money, that would have made a huge difference in how we could cope with the pandemic now. We didn't get that money, and so we've had to make do. And in Nottingham, our estate is very old, and it doesn't have many separate rooms. But right here, right now, the money's not a limiting factor. The limiting factor is our estate and is our workforce. The nursing workforce in particular are really stretched. And, if we wanted to open half a dozen extra wards, well, we don't have the nurses to man those. So we don't even have the nurses to open a single extra ward. So that's why we have to take down certain elective activity in order to allow the emergency stuff to continue.
Yeah, okay, thank you. So inevitably, waiting lists are likely to grow as activity has been reduced. What are your concerns about the people that you're not seeing at the moment?
Well, I'm very concerned about the people that we're not seeing. I mean, all the work that goes on in a trust, all the patients that we see are patients that need healthcare. It's not optional most of the time. Now, elective surgery can wait by definition. It's not something that is emergency or urgent that needs to be done in the next month, but it should be done in a timely way. And we are seeing patients who need surgery or need treatment of some sort who we aren't able to offer that right now. And so waiting lists are going to increase, and there will be some patients who will come to harm. We're very clear with our patients that if they're concerned about coming to harm, that they need to get back in touch. and we will do our utmost to expedite. But nevertheless, we can't do everyone right now. And so there will be the risk of patients coming to harm whilst waiting on a waiting list.
Within the trust, what might you do differently to try and mitigate some of those concerns about those patients?
Okay, so I mean, there's always things that we're trying to do in order to do more for our patients. One of the things when we don't have COVID patients, when the COVID rate drops and COVID patients are able to return home and empty out those wards, then we will very rapidly start up the elective program again. And then we'll be looking for more. And that's what we've been doing over the summer is, how can we get back to normal? How can we be even better than normal? And, working weekends and evenings and so forth. And the other thing that we have done over the first wave is work very closely with our independent sector colleagues. And that's been great because there's not much private work going on. And so using that capacity for our NHS patients has been really useful. And we're trying to do that again. But obviously the first time around there was a national contract between the private providers and the NHS, government-led, that isn't in place at the moment, and that's causing a little bit of anxiety, but we have good relationships with our local independent sector, and we're hoping that we can continue to use that resource, because without it, then patients are going to wait significantly longer. So there are lots of things that we can do, but ultimately we have a limited resource, and it has to respond to the emergency patients first. And right now it's COVID. Continue to do as much elective work as we can, but there is only that limited resource.
Yeah, okay. So I'm going to guess the answer to this question, but are there any opportunities, or would you be looking sort of within surgical pathways to make changes that might have a positive impact on efficiency, for want of a better word?
Yeah, so I mean, that's one of the things that I've been particularly interested in over my 3 years as Divisional Director. How can we make elective surgery more efficient and best practice? And of course, if we had the perfect real estate, if we had the perfect hospital, it would be a lot easier. We don't. We have quite an old estate, and so there is the limit, and that elective work is not protected from the emergency work that we have to do, which I've just been talking about, and that is one of the restrictions and prevents the efficiency that I would like to see. But it's very much something that we're interested in, making sure patients are at their peak fitness before their surgery, the prehabilitation as we call it. Then they come in, have enhanced recovery protocols during their recovery from surgery, as well as minimally invasive and robotic type procedures, which we're keen on. And then post-op, there's the post-rehabilitation, trying to get patients fit again as quickly as possible and reducing readmissions. So those are all things that I've got a real passion about, that we're really interested in, to try and make sure those patients are treated in the most efficient way for them, but also in the most efficient way for the hospital and for taxpayers' money.
Yeah, okay. You talked there about prehabilitation. Are you doing anything with the wider system? Obviously, we're on a road to integration in the NHS. Are you doing anything with the wider system to help reduce the need for surgery in the first place?
So yeah, absolutely. We have one of the largest specialties that I deal with is orthopedic surgery patients with hip and knee conditions, often arthritis, often requiring hip and knee replacement. But we know that if they see physios, along the journey, then that can give them a good quality of life for a period of time before they absolutely need their joint replaced. So we have community hubs where patients are referred up for for their knee pain, and then they're seen by physios, and they have a prehabilitation program to try and get them avoiding surgery ideally, but if they can't avoid surgery, then at least get them as fit as they can before their operation. So that's really important, and we're working across the integrated care service in the whole of Nottinghamshire to make sure we do as much of that as possible, delivering care close to the patient's home where that's possible.
And in terms of the surgery element of that, is something that the Trust's leading, or is it really a system effort to address the needs of the population?
Well, it's very much a system-led thing, but our Trust is very much at the heart. Our chief exec actually is also the chief exec of the system, integrated care system. So, we're very much in the heart of that. But yeah, we recognise that if a patient can be treated in their local GP practice, why would they want to come up to hospital for the same treatment? It's much more convenient for them, and it's probably cheaper as well. So yeah, absolutely. But we've got to make sure that's safe and of a good quality.
Yeah. Okay. Well, sort of, I suppose most prevalent, most prolific means of addressing the NHS's needs over the COVID pandemic has been the introduction of virtual consultations, or at least the acceleration of the implementation of them. In terms of that move, how do they impact on your own clinical practice, and do they affect the way that patients actually engage within a consultation?
Yeah, I mean, that's been a really interesting and a very positive thing from COVID. And, for every disaster like a pandemic, there are always lessons that we learn and good points that we can take away. And this, I think, is one of them, the virtual consultation. It's something I've been trying to promote for a number of years, but the traction has been quite slow. But suddenly, within a few weeks, everyone was doing it. And, it was slightly uncontrolled, but, and you could argue that the pendulum swung a little bit too far, and I'll explain what I mean by that. But, I mean, most of the patients that we see in the clinic are now telephone-based clinics, or video consultation. So we're rolling out video consultation in the Trust. But, that takes a little bit of time. But there's a lot you can achieve with the patient over the phone or over the internet video consultation. But of course, you can't examine the patient, so there is a limit. And sometimes you can't, there's a lot of non-verbals that you can't get as well if you're just doing it by phone, which is the way I've been doing it, simply because our clinic hasn't been prioritized for the video consult yet. But yes, so there's a lot we can achieve with the virtual clinic, but one of the things that we do with virtual clinics is, we're normally being presented with a patient who has a provisional diagnosis, and we still have to arrange for them to have imaging and so forth, which they're going to have to come up to the Trust for. Once we've got that imaging result back, we can come up with a diagnosis and a management plan. But then, of course, you have the whole informed consent, shared decision-making process, which is really important. And we're used to doing that face-to-face with the patient, but we're having to think about doing that remotely now as well.
So how feasible is that shared decision-making? Is it a significant shift in how able you are to do that?
Well, it's a barrier. So the fact that we can't eyeball the patient directly and have the non-verbal communications is a slight barrier to shared decision making. But obviously, so long as they can understand English and speak to us, then we can share that information. And one of the things that we do is give patient information to the patient, and we can email that to them, and we can use digital technology now to deliver that information. And so long as they can receive that information, then that two-way communication, that interaction between the doctor and the patient can still happen. It's something I feel very passionate about, and in fact, I work with a company called IDO Healthcare that I've been involved with right from the beginning 20 years ago. And that's all about sharing information with the patient in a way that the patient can understand. Traditionally, it was a paper form, but now we've developed the technology to be able to deliver that digitally. And so that really helps helps get over those barriers of the breakdown in or the restriction with the virtual consultation. And it remains absolutely key. You know, we have to have the patient being fully on board with the treatment that we're recommending. Otherwise, you know, we're not doing the best for our patients.
Yeah, that's really important. And we've heard, certainly I've heard from colleagues in primary care that actually patients being in their own environment at home can actually sometimes be really positive because they're feeling, you know, safe in their own cocoon almost. Do you find that in terms of patients sort of digesting information and being able to come to the right decision, is a home environment preferable for them than a clinical environment, or have you not really noticed that?
Well, I think it is. I think, you know, the fact that the patient, if they can absorb and read information in their own time, not just in the pressure few minutes that they're with the doctor, that's really important for the patient to actually understand and come to a decision. And yes, that has to be facilitated with a conversation with the clinician, because, you know, the patients need that. They need someone to be able to ask questions of things that they don't understand. So that's absolutely essential. But yes, it does. The fact that they're in their own home and there isn't the time pressure in quite the same way, that's good. It doesn't help, of course, on the odd occasion where I've phoned a patient up and they didn't realise I was going to be phoning up and they were asleep in bed. That's not the ideal consultation. There's being relaxed and there's being over relaxed.
Yeah, absolutely. Yeah. Just pulling you back to, you mentioned in terms of the virtual consultations, it's something that you've been trying to implement for some time in the trust. It's happened overnight, literally, in some cases within the NHS, that these technologies have come in. Do you get a sense of frustration that you spent a lot of time and then it was just one pandemic switched things on overnight, or do you see that just as a positive?
I see it as a great opportunity, and we absolutely need to build on that. I think it was a frustration before when there was it was quite a slow uptake initially. I'm a believer in the single meaningful consultation. That is, once the patient needs to come and see me as the surgeon, once all the results are in and we know exactly what the problem is, I don't need to see the patient face to face to say, I need to send you for a test. So that's what we're working towards. We're working towards being able to get all the results together, inform the patient of what the problem is. These are the suggested, and now come and see the surgeon and have that single meaningful consultation where they can look me in the eyes, I can look them in the eyes, I can examine them, I can see what issues, problems we might anticipate at surgery, and we can have a discussion about the risks and benefits of surgery. and then we can make a joint decision together. So I think, you know, that's what I've been trying to promote over the years, and I think the experience with the pandemic has really brought that forward and accelerated that.
Yeah, okay, thank you very much. Obviously, we're talking about the virtual world or the digital world that we're living in, increasingly living in. Do you see further opportunities, and do you have an appetite for looking at new technologies to help improve the standard of care throughout the trust, throughout your system?
Yeah, absolutely. Look, I mean, we know that industry have a really important part to play, and in my role as Director of IDO Healthcare, I'm involved in that to some degree. And you know, any good idea, any good solution is something that not only will work in Nottingham, but will work across the NHS and indeed across the world. And that's the business model that, you know, IDO have come up with. And that's true of all the other providers out there and industry partners out there. You know, they've got a solution to a problem. Now, not every solution will work in every situation, but you know, if it's a good one, then it will. And of course, getting that digital technology to work in our hospitals for the benefit of our patients is something I feel passionate about. And actually Nottingham also sees that as a key way forward, so that we can help each other, industry and the NHS, to develop patient pathways which are efficient. We all recognize, you know, the technology we have in our pockets, the phones that we have, you know, communicating with our patient. We can give them all that information whilst they're sat at home relaxing. And you know, that reduces the burden on patients having to come up to hospital. It also saves money for the trust in terms of keeping the patients out of hospital when they don't need to be there. So there's huge things that we can do, and I think we're probably at the beginning of the curve of improvement in the NHS. You know, where technology in some ways is very advanced in terms of our imaging and that sort of thing, but in terms of our computer systems that we in, there's a lot to learn from other industries. If you think about financial technology, you know, I'm sure that if you know, we've all used banking apps and the technology just works brilliantly, doesn't it? Why can't it work like that in the NHS? And that's what a sort of again, another passion of mine. I feel that we can really revolutionize health technology in the next few years.
And would there be particular points in pathways that you're particularly looking at? Is it detection, diagnosis, treatment itself, or is it looking, you know, very open-mindedly at, if the right things are out there, let's try and embrace them?
I think all parts of the patient pathway. I mean, I think the imaging technology that we have is actually very good. I think that, you know, we've talked about virtual consultations, and there are a lot of partners coming into that space now, but it's a rapidly developing field. But we haven't got a single product that really does everything, and it can be improved. So that's a really important development area, which everyone appreciates at the moment. But you know, there's electronic referrals and how we can triage those referrals so that the patient goes to the correct place without having to see me as the surgeon. I only need to see the patients who've had the tests done and have come back with a condition or a problem which I can help with. So, you know, that referral-based system is, you know, the digital enhancement there is really important, because, you know, we see there are a lot of referrals which are unnecessary. And that's not putting any blame on anybody. It's just the GP's not sure whether this is a referral for hospital or not. Whereas if we had an electronic triage system, we could sift out and make sure the necessary information is accompanied by the companies, the referrals. And then, of course, there's reducing length of stay. That's really important. So can we manage patients at home, send them home a little bit earlier than we would do, but monitor their vital signs at home, hospital at home type technology. Again, all that is developing, and we need just to bring all those things together in a coordinated way, so that we can offer the most efficient service for our patients. But again, if it's good for our patients, it's also cost effective and good for the trust.
Yeah, absolutely. Yeah, and would you hope to see more self-care amongst patients as a result of technologies?
Absolutely. I mean, promoting self-care is really key. Patients do have to take responsibility for their health, and it's not about just going and being sorted out by the doctor. People understand much better these days about risk factors and balancing those risk factors. And chronic conditions are a really good example of how the patient, with some testing from the NHS, we can inform the patient of how they're doing on their chronic condition and what their markers are, and are they beating this disease, or do they need to come in and have a further consultation for advice. And actually, many patients don't need to come and see the doctor once they are empowered to understand and to be able to monitor their chronic condition without the doctor being involved, but knowing that they've always got that call back into the system if they need it.
Yeah, okay, fantastic. So as we're coming into winter, as a light-hearted end note, if you could write a list to Santa, what one thing would you ask for? If he was a health tech company, what one thing would make your life easier if you had a technology there?
Well, I was going to say a new hospital. I suppose that covers a number of technologies. Well, right now, I guess the problem is not primarily a technology solution. That what we need now is more nurses, and to improve or encourage and support the morale of our nurses. So, that's very much a human thing, obviously, and maybe that's not the answer you want, but that's the biggest thing that we could do with right now. And I have to say, the sort of the clap for heroes, that we had in the first wave was immensely powerful at encouraging the NHS staff who were working above and beyond, and maybe that sort of thing doesn't happen now, and of course we wouldn't expect it, but the NHS staff have continued throughout the whole period to do more and go above and beyond, and it's difficult as a manager to keep asking for more and asking for more. We've got a brilliant, our greatest asset is our healthcare staff, and we just need to look after them and support them a little bit, because it's going to be a tough winter for everyone. So if you've got some digital technology that can do all that, that would be great.
I'll have a look in the garage. And we've got a couple of minutes left. So what do you think your staff would ask for? Is it just understanding from the public that this really is a big issue? Is that the main thing that staff would ask for?
Yeah, I think staff would ask people to, comply with the lockdowns and restrictions that we have, because they're not perfect, but they're there to reduce the spread. We have to reduce the spread of this disease. They would ask that people look after themselves and pay attention to those risk factors like the obesity and so forth that we can do something about. So that would be the biggest ask. And our patients they're always delighted with the care that they get. They don't they're not the most demanding patients. They're just so appreciative of the care that they get in hospitals. So, I wouldn't say anything to our patients. They need to be there, and we will look after them and make sure that they get the best treatment. But obviously, for the community outside, look after each other, do the necessary precautions so that we're not having to spread this infection further than is absolutely necessary.
Wonderful. Thanks very much, Simon. Those are, I think, good words to end on there. Sound advice. So thanks, Simon, for joining me today. And thank you, everyone at home, for listening. We will be back on November the 13th with Dr. Peter Brambleby, who's a Interim Director of Public Health, to have a look at the public health situation around COVID and how public health is working with the NHS to overcome this pandemic. So thanks again. Look after yourselves, and we'll see you next time.